So hello students, our today's subject is oral surgery. So let us discuss the MCQ. The first question is, the patient had a fall resulting in mid-symphyseal Goalmds fracture. While reducing the fracture, the lingual splaying of the segment was noted. So this will cause an increase in, so the answer is C, that is the interangular distance. So first of all, the Goalmds fracture is a symphyseal and bicondylar fracture that you should know. So a Goalmds fracture, it is a symphyseal and bilateral condylar fracture. So here in this CT scan, you can in the CBCT you can see this region is showing the mid-symphysis region fracture. So this region getting fractured and the bilateral condyle fracture. So for entrance exam, you have to just remember that the Goalmds fracture, it is symphyseal, remember, and bilateral condyle fracture. So it is the other name remember the other name is, it is also known as parade ground. Parade ground fracture. So it is also known as parade ground fracture, symphyseal and bilateral condylar fracture. So the lingual splaying, what does that mean? The lingual splaying in the question means that there is outward displacement of the separation of the lingual surface of the fracture bone. So you will see there will be separation of the lingual side of the fracture bone will get separated, particularly in case with the symphyseal fracture. Along with the, so here there will be separation on the outer surface. So symphyseal fracture, it's a fracture in which involving the midline of the mandible where the two halves of mandible they will meet. Whereas the lingual splaying, it refers to the inner side facing surface of the mandible. So when the fracture segment, they are displaced outerwards on the lingual side. So this outward movement will cause the lingual surface of bone to spread apart. So it will create a gap or separation between the teeth. So it can affect the alignment and stability of mandible. So what you will see, there will be malocclusion, difficulty in chewing and speaking. So proper reduction, realignment of the fracture segment and adequate fixation, they are required to restore the normal function. So the interangular distance means the width from the angle of that means that width or distance between the two angles of mandible. So the interangular distance, it is distance between angle of mandible So lingual splaying of the mandibular fracture, in case with the Goalmds fracture, it can cause increase in the interangular distance. So that is because the splaying or spreading apart of the fracture segment that can result in wider separation between the mandibular angles. So option A is interpupillary distance. Well, the interpupillary distance is the distance between the two center of the pupil of eye. So that cannot be the answer. Intercanthal distance, it is the distance between the inner corners or the canthal of the eye. Even that is not the answer. Option D, Gonian-Ganathian distance. It is used to measure the length of the mandibular body. So this Gonian-Ganathian distance is primarily concerned with the length of the mandibular body rather than the width of separation of the angles. So answer of choice is the interangular distance. Option 2. Let us discuss the next question. What is the recommended needle withdrawn technique after the administration of intraligamentary anesthesia? So your answer is leave the needle in place for several minutes after the injection. So this technique here shows the intraligamentary injection. So after administration of the intraligamentary anesthesia, it is recommended to leave the needle in place for several minutes. So that allows for the better diffusion and distribution of anesthetic solution within the periodontal ligament space. So this space. So that can enhance the effectiveness of anesthesia. So leaving the needle in place for a few minutes helps to ensure that anesthetic solution has sufficient time to take before the dental procedure is being performed. So this intraligamentary injection technique, as described in this pic, it's also known as periodontal ligament injection. So this technique involves the injection solution. It is given directly into the periodontal ligament space. So it's given in the periodontal ligament space that surrounds the tooth root and connect them to the bone. So you have to just insert the needle into the gingival sulcus or directly into the periodontal ligament space. So the needle should penetrate gingiva and reach the periodontal ligament space. Perform an aspiration by pulling back slightly to check for the blood. Administration, a small amount of 0.2 to 0.3 ml of the solution into the pedial ligament space. So remember, while injecting, you have to leave the needle in place for several minutes after the injection. So answer is B. So that helps to ensure that anesthetic solution has sufficient time to take effect before the dental procedure are performed. That will increase or enhance the effectiveness of the anesthesia. There will be better diffusion and distribution of the anesthetic solution within the periodontal ligament space. Next question. During a lingual nerve block, the needle is inserted into which area? Well, during a lingual nerve block, the nerve, it is inserted into the sublingual space. So this one is the sublingual space. So this nerve block technique, it is used to anesthetize the lingual nerve that will provide the sensory innervation to anterior 2/3 of the tongue. So anterior 2/3 of the tongue. So the solution, it is injected into the sublingual space to block the nerve effectively. So our goal is to anesthetize the lingual nerve. that provides the sensory innervation to anterior two-thirds of the tongue. So to effectively block the lingual nerve, the injection needle is typically directed close to the lingual nerve pathway without directly touching it. So you have to give the injection in the sublingual space, that is located beneath the tongue and within the oral cavity. So the needle, it is inserted into the sublingual space. It is positioned in proximity to the lingual nerve, and once it is done, just deliver the anesthetic solution. You have to just deliver the anesthetic solution so that it diffuse and block the nerve function without causing any direct injury to the nerve itself. So answer here is A. Another question. During a go-gate mandibular nerve block, the patient experienced paresthesia in the ipsilateral ear and posterior one-third of the tongue. So, what nerve could be inadvertently affected in this case? The answer is auriculotemporal nerve. Well, during a go-gate nerve block, where do you give? Where is your target area? The target area is near the neck of condyle. So this region is your target area. So targeting the mandibular nerve, a branch of trigeminal nerve. So the needle, it is inserted near the neck of condyle of the mandible, targeting the mandibular nerve, that is a branch of trigeminal nerve. In some cases, the needle may affect the auriculotemporal nerve, this nerve, that is the another branch of the trigeminal nerve. So this auriculotemporal nerve instead of this inferior alveolar nerve, sometimes your target area reaches the neck of condyle, means here, that may anesthetize the auriculotemporal nerve. So that we know that auriculotemporal nerve, it provides sensory innervation to external ear and skin over the TMJ joint. So when this nerve is affected, what will you see? That will cause paresthesia in the ipsilateral ear, same side of the ear, and posterior one-third of the tongue. So your answer is auriculotemporal nerve. Hope the answer is clear now. Moving to the next question. After an infraorbital nerve block, the patient reports numbness in the upper lip, but the teeth remain sensitive. So what could be the cause? The answer is C. So when the patient reports numbness in the upper lip but sensitivity in the teeth after an infraorbital nerve block, that the cause of it is incomplete diffusion of the anesthetic solution. So infraorbital nerve, we know it is administered to provide anesthesia to the maxillary teeth and surrounding soft tissues, including the upper lip. As the infraorbital nerve, we all know that it innervates these areas. So if the anesthetic solution, if it does not diffuse and reach all the nerve branches, or there is insufficient time for the solution to take effect, what the patient would experience an uneven or incomplete numbness. So it is incomplete diffusion of anesthetic solution. It is most likely the cause of this. So the answer is C. Moving to next question. During an inferior nerve block, the patient reports a tingling sensation in the lower lip and chin, but the teeth remain sensitive to stimulation. What could be the cause? So The cause could be accidental injection into the mental nerve. So, a tingling sensation in the lower lip and chin. So, if during inferior alveolar nerve, the goal is to anesthetize the inferior alveolar nerve. So, if the needle, it anesthetizes the mental nerve, a branch of inferior alveolar nerve that is responsible for innervating the lower lip and chin, it can lead to numbness or tingling sensation in those areas. While the teeth, they may remain sensitive. In go-gate mandibular nerve block, which nerve block is primarily anesthetized? So we know the go-gate mandibular nerve block, it is technique that is used to achieve a profound anesthesia of the entire mandibular nerve division. The main target of this block is the inferior alveolar nerve. So that provides sensory innervation to the lower teeth and surrounding structures in the mandible. As we know, the primary target of the inferior alveolar nerve the injection for the inferior alveolar nerve, it is given near the mandibular foramen, that is located at the posterior border of the ramus of mandible. So the anesthetic solution, it is delivered close to the mandibular foramen, whereas so our target area in that inferior alveolar nerve block is the lingula, whereas in the go-gates mandibular nerve block, a profound anesthesia of the larger portion of the mandibular nerve is our aim. So the primary target is the mandibular nerve itself, which includes the inferior alveolar nerve and other branches of trigeminal nerve. So our target area here is the neck of the condyle. So the go-gates technique, it does not anesthetize only the inferior alveolar nerve block, but it also anesthetize the other branches of mandibular nerve like the lingual, buccal, mylohyoid nerves, that results in more comprehensive numbness in the lower jaw, teeth and the surrounding soft tissues. So the primary nerve anesthetized is the inferior alveolar nerve. Next question. A patient presented with a tingling sensation in the tongue with a difficulty in the speech and swelling. So which nerve block has been affected? The answer is the lingual nerve. Very easy question. Moving to next question. What should the dentist do if the patient experiences an adverse reaction following an inferior alveolar nerve block? So if the patient experiences an adverse reaction following inferior alveolar nerve block or any dental procedure, the dentist initial response should be to monitor the patient closely and document the reaction. So that will allow the dentist to assess the patient condition, provide an appropriate care and maintain the record of the incidents for the future reference. So depending upon the nature and severity of the reaction, further action that may be required, such as administering emergency medicaments or referring the patient to specialist. So however, closely monitoring the patient and documenting the reaction are the essential first step in managing the adverse events during the dental procedure. So answer is definitely A. After positive aspiration, the dentist withdraw the needle and reposition it during an inferior alveolar nerve. What precautions should the dentist take before injecting the anesthetic solution. So the dentist has to aspire again to confirm negative aspiration. So when a dentist withdraw the needle and reposition it during the injection procedure, it is crucial important to aspirate again to confirm the negative aspiration. So you have to check whether the needle is either positioned within a blood vessels before re-injecting the anesthetic solution. So aspiration involves the pulling back slightly on the syringe plunger to check for blood. So if the blood comes during the aspiration, that indicates that the needle is in blood vessels and injection into the blood vessels should be avoided. So injecting the medications or anesthetic solution directly into the blood vessels can lead to various complications like the systemic toxicity. If the medicaments or anesthetic solution is injected into blood vessels, it can enter the bloodstream, leading to systemic toxicity that can cause symptoms like rapid heartbeat, shortness of breath, confusion, etc. It can affect the cardiovascular. It can have cardiovascular effects like the arrhythmia, irregular heart rhythms, increased blood pressure, increased BP, or even a heart attack in susceptible individuals. There could be neurological effects like loss of consciousness, confusion, paralysis. Apart from that, local tissue damage can occur, allergic reaction or hematoma can be the complication associated with it. So you have to aspirate again to confirm the negative aspiration. That is the answer of choice. A patient develops seizures and tremors on administration of LA due to the lignocaine overdose. So the level of lignocaine that cause CNS toxicity it is. So it should be. So the answer is A. It should be greater than 7.5. So it should be greater than 7.5 microgram per milliliter. So lignocaine, we know it is a local anesthetic, and excess level of it in the bloodstream, it can lead to CNS symptoms like the tremors, seizures, and other neurological disturbances can occur. So remember this value for your entrance exam point of view. Next question, a patient was on 20 milligram hydrocortisone for 4 years and was advised to extraction. So during extraction, he started experiencing lethargy, weakness and palpitation. The treatment was discontinued and he was prescribed 100 milligram hydrocortisone. What is he being treated for? The answer is C, adrenal insufficiency. So the patient here is being treated for adrenal insufficiency, also known as Addison disease or secondary adrenal insufficiency. So in this case, the patient has been on long term, the maintenance dose is 20 milligram, right? Likely to replace the deficiency of adrenal hormone production. So when undergoing the tooth extraction, the stress of the procedure could have increased body demand for the hormone cortisol. So it is a hormone that is produced by the adrenal glands. So that can lead to symptoms like lethargy, weakness and palpitations. So to manage the increased demand during the procedure, the patient hydrocortisone dose was temporarily increased from 20 milligram to 100 milligram. So that is done to ensure adequate cortisol level during the period of physical stress or illness. So as we know, cortisol, it is a steroid hormone that is produced by the adrenal glands that are located on the top of each kidneys, so that it plays a role in body response to stress. So that is why it is also known as stress hormone. So when the body perceives a stress or threat, the hypothalamus pituitary adrenal axis, it is activated. That signal the pituitary gland to produce ACTH, that stimulates the adrenal glands to release cortisol in the bloodstream. So this cortisol, we know it will cope with stress by increasing the blood sugar level. So this was the normal etiology. The answer here is C. Let us move with another question. A patient with a history of diabetes came to dental clinic for tooth extractions. While on chair, he experienced hypoglycemia and he suddenly fall down with the low BP on the dental chair. So what should be your immediate line of treatment? Well, the patient experienced hypoglycemia. So immediate line of treatment should be to give dextrose. Dextrose 50% is concentrated IV solution that will provide a rapid source of glucose. So that will raise the blood sugar level in case with the severe hypoglycemia. So that will restore the consciousness and stabilize the patient BP. So dextrose 50%, it is generally used. So answer is B, dextrose 50%. Let us move to the next question. A 35 years old patient required extraction of left upper molar, but since she presented with exophthalmos, tremors and increased blood pressure. So what should be the operating surgeon suspect? So symptoms here described in patient are exophthalmos, that is the bulging eyes. So these bulging eyes, tremors and increased pressure, so that will suggest hyperthyroidism. What is hyperthyroidism? That means there is overactivity of which gland? Thyroid gland. So that will produce excess which hormone? Thyroid hormone. Right. Exophthalmos, it is the protruding or the bulging eyes. The tremors that are involuntary rhythmic movements that can be associated with hyperthyroidism. So answer is definitely hyperthyroidism. A 50-year-old patient with history of chronic alcoholism required multiple extractions. Which of following he should be prone to? So he should be prone to increased partial thrombin time. So the chronic alcoholism, it can lead to liver dysfunction. So liver, we know it is responsible for producing clotting factors like the prothrombin. That is essential for the clotting cascade. In the alcoholic liver disease, there will be impaired synthesis and decreased level of clotting factors that can lead to prolonged PT. So increased PT indicates there is deficiency in the clotting factors and there is increased risk of bleeding, making patient with chronic alcoholism more prone to the bleeding complication. Remember the partial thromboplastin time, it affects the intrinsic pathway and it is not affected by chronic alcoholism. Whereas the prothrombin time, it assesses the extrinsic pathway. Moving to the next question. A patient with iron deficiency anemia came for extraction of impacted wisdom tooth. Which of following would be contraindicated for such procedure? The hemoglobin level of 7 mg per deciliter, it's below the normal range, and it will suggest a severe anemia. So anemia is a condition that is characterized by the low red blood cells count. So the blood has reduced oxygen carrying capacity. So performing surgical procedure like extraction of impacted wisdom tooth can be risky and can lead to complication that is due to the reduced oxygen supply to the tissue. So A is contraindication for such procedure. A patient 58 years old came to oral surgeon with rheumatoid arthritis. The most common complication of TMJ is ankylosis. Rheumatoid arthritis, it is an autoimmune disorder that can affect the multiple joints in the body, including the TMJ. So ankylosis, it refers to the abnormal fusion or immobilization of joint that can occur as a complication of these rheumatoid arthritis. So the most common complication is ankylosis. The most common is, remember, ankylosis. So ankylosis in TMJ can result in severe limitation in jaw movement, difficulty in opening and closing the mouth, etc. Whereas the option MPDS, it can occur. It is not specific to rheumatoid arthritis and occur in individuals without RA. The internal derangement refers to the structural abnormalities within TMJ like displaced disc dislocation or malpositioned joint components that can cause pain, clicking, popping sound, and limited jaw movements. Osteoma of condyle, it is a benign tumor that can occur in various bones, including the condyle of mandible. Osteoma can develop in TMJ. They are relatively very rare, and it is not specific to RF patient with TMJ disorder. So, most common complication is ankylosis here. A cardiac patient came to dental office with signs and symptoms that commonly suggest that cardiac failure. Him being assessed for oral surgeon are So the ankle edema, that is the swelling of the ankles, it is common suggestive of congestive heart failure. So that occurs because the heart's pumping ability is compromised. That will lead to fluid buildup. In the extremities, including the ankles. Dyspnea means the shortness of breath. It is another hallmark of the heart failure. As the heart's ability to pump blood decreases, it can lead to fluid accumulation in the lungs. So that fluid accumulation in the lungs, that will cause difficulty in breathing. So other options may be associated, but they are not specific to cardiac failure, and they are less likely to be directly related to heart failure. So answer here is C. Moving to the next question. Patient receive heavy blow to the right body of mandible, sustaining a fracture there. You should suspect a second fracture. That is most likely the answer should be C. So when a patient sustained fracture to one side of the mandible, particularly in the body of mandible, in the case here is right side. So there is possibility of second fracture. So that is the second fracture, the traumatic forces that can result in fracture at multiple locations due to transmission of energy through the bone. So the fracture on the right side of mandible may be associated with the fracture on the contralateral. So fracture of it may be associated with on the contralateral side. So that is why you should suspect a second fracture in the left subcondylar region. So that is why assessing a patient with mandibular fracture, it is crucial to conduct a thorough examination, including the radiographic imaging, to identify any additional fracture that may not be immediately evident. Next question. A 65-year-old woman arrived for dental therapy. The questionnaire shows that she is suffering from severe cirrhosis. So the problems that can be anticipated in the routine dental therapy is, the answer is B, tendency toward prolonged hemorrhage. So in patient with severe cirrhosis, there is concern regarding blood clotting and coagulating factor. Cirrhosis, it can lead to impaired liver function. So that can results in decreased clotting factor. There will be decrease in the production of clotting factors and platelets. So if the platelets gets decreased, there is increased bleeding. And so that is why the patient there is tendency toward prolonged hemorrhage. So the routine dental therapy like extraction, periodontal treatment, they can lead to bleeding. And patient with cirrhosis, this bleeding tendency is of particular concern. The most Culprit for the maxillary sinus infection of odontogenic origin, it is due to the anaerobic bacteria. The bacteria mostly associated are the Streptococci and Staphylococcus aureus species. So the answer is B. Moving to next question. A 47-year-old patient was suffering from severe headache and heaviness of the face since 4 years. On further examination, it was noted that there was inflammation of most or all the paranasal sinuses simultaneously. So you can see here there is so the term we use is pansinusitis. It is term that is used to describe the inflammation or infection involving most or all the paranasal sinuses simultaneously that can affect multiple sinuses including the maxillary, ethmoid, frontal, sphenoid sinuses. So the term is pansinusitis. A 8-year child was diagnosed with fracture in twin jaws and it was further noticed it was a single fracture line. What is the best way of treating such a fracture? The answer is cap splint fixation. So the cap splint fixation involves the use of orthodontic appliance or cap splint to stabilize the fracture jaw. So it is common method of treating single fracture line in both jaws, especially in the pediatric patient. So this will allow to align the jaw properly and promote healing of the fracture. The intermaxillary fixation that involves the wiring of the upper lower jaws together to immobilize them. The Rifden wiring, it is used for the treating mandibular fractures. Transosseous wiring involving the passive wires through the bones to stabilize the fractures. So that technique is used for certain types of fracture, but it is not the primary method for treating single fracture line in the both jaws. A 20-year-old patient met with bike accident and CT revealed a disc unfavorable fracture in the mandibular angle region. So during surgery, it was seen that it was a fairly difficult fracture to treat. This might be because of distraction of the fragment segment by the muscle pull. So these are the muscles that will make it unfavorable fracture. So a display of unfavorable fracture in mandible angle region, it is challenging to treat because of the muscle forces in this area. The muscles that are attached to mandible, like the masseter, pterygoid muscle, they can pull the fracture segment. That will make it difficult to align properly during the surgery. A 40 years old female with clicking in her right TMJ for last 6 months. She does not have any pain or limitness of her mouth opening. The clinical examination does not reveal odontogenic cause. What could be the most likely represents? The answer is C, internal dearrangement of TMJ. The most likely condition here is TMJ. The clicking or popping in the TMJ without associated pain or limited mouth opening, it is presented with the internal dearrangement of TMJ. It can involve like disc displacement, condyle dilation, disc condyle abnormalities, etc. The patient with internal dearrangement may experience clicking, popping sounds as they open or close their mouth. Whereas the TMJ ankylosis, it refers to the immobility of the fusion or immobility of the TMJ. that would result in limited mouth opening. Fracture of mandibular condyle could lead to pain, swelling, and limitation of the mouth opening. Myofascial pain, it involves the muscle-related pain and it is not directly related to TMJ clicking without other symptoms. So answer is C. A female patient complained of pain in her right ear radiating toward the angle of mandible. Clicking sounds were present in right TMJ joints. Result of palpitation and radiographic examination, they are negative. The most probable diagnosis, it is C. So myofascial pain dysfunction syndrome, MPDS, it is condition that cause pain and dysfunction in the muscle that controls the jaw movement. So that presents with the ear pain, jaw pain, clicking, popping sound in the TMJ and referred pain to the ears and the surrounding structures. Osteoarthritis of TMJ, it may cause pain and limited jaw movement but involves the radiographic changes, like you will see the joint space narrowing and bone changes that are not mentioned in this case. So that's not the answer. Rheumatoid arthritis, it can affect the TMJ and cause pain and dysfunction, but it is usually associated with other systemic symptoms. Traumatic arthritis, it occurs after the specific injury to TMJ. It can cause pain, dysfunction, and it has a traumatic event associated with it. So answer is C. Halkimo index, it is used for objective evaluation of TMD disjunction. It was asked in your recent exam. It is used to classify TMD, temporomandibular joint disorders. The interposition materials that restrict the heterotopic bone formation in patient treated with TM ankylosis with the fat. So in the patient treated with the TM joint ankylosis, the autologous fat graft. So the fat graft, they are used as interpositional material during the surgical procedure. So why we use them? We use them because the purpose is to obliterate the dead space around the joint prosthesis. So that would restrict the formation of hematoma in the joint space. So that can limit the heterotopic bone formation and promote better outcome following the TMJ surgery. Deep antegonal notch, it is a feature of TMJ ankylosis. So this is the difference between the unilateral ankylosis and bilateral ankylosis. So very important question, very important to know that in unilateral there is deviation of chin to affected side and bird face deformity is seen in bilateral TMJ. So remember all these differences between unilateral and bilateral ankylosis. In unilateral ankylosis, you will see flattening and elongation on unaffected side. In bilateral, the mandible is symmetrical but micrognathic. So there will be retrognathic mandible. Moving to question, the new concept in etiology of TMJ ankylosis, it's the hypercoagulability of the blood. So hypercoagulability of the blood means the blood, it has increased tendency to clot. So TMJ ankylosis, it can result from, as we know, that can result from the trauma or injury to the temporomandibular joint. So this trauma can lead to bleeding and hematoma, that is accumulation of blood within the joint. So in individual with hypercoagulability state, the blood is more prone to clotting. So when trauma will occur, the hypercoagulable blood, it will form more clot more readily with the joints, including the small blood vessels. So the blood clot will organize, leading to formation of fibrous tissue. So this fibrous tissue can result in the fusion or ankylosis of TMJ. So as the fibrous tissue accumulates and harden, it can restrict the normal function of TMJ that can cause ankylosis. So it was asked in Neetmds SR-shape exam. So remember, this automatic external defibrillator, it is not used to perform CPR for an extended period. Instead, its primary function is to assess the patient cardiac rhythm and, if necessary, deliver an electric shock to the heart in order to re-establish the proper rhythm. So your answer is B here. Moving to the next question. When a patient pulse is being taken, her arm should be well supported, extended, and positioned at the same level or lower than that of heart. So why this position is important? So this position is important to ensure an accurate measurement of the pulse. So placing the arm in a position that is not supported or above the heart level, it can cause inaccurate reading. Supporting the arm and having it at appropriate level, that helps to maintain the consistency and accuracy. So placing the arm at same level or lower than that of heart, it helps to ensure that the gravity does not affect the blood flow. That can even lead to inaccurate reading. The arm should be well supported, that prevents the muscle tension or fatigue that could also affect the pulse measurement. Moving to next question. So your answer here is D. Moving to the next question. A 18-year boy has suffered a hairline undisplaced fracture without any mobility. So treatment of this choice is, so here is the fracture. So in case of undisplaced mandibular fracture, when there is no mobility, so the fracture here is stable. Conservative management with close observation for natural healing, it is the common approach. Surgical intervention like open reduction and fixation with a rigid plate or wiring, if typically it is reserved for the cases with significant displacement, mobility or associated complication. So your answer is D. Observe for fracture healing and no surgical intervention. That is the correct answer of your choice. A cricoid hook, it is particularly used in cricoid hook, it is a surgical instrument that is commonly used during the tracheostomy procedure, that is used to retract. So it is used to retract and stabilize the cricoid cartilage, a ring-shaped structure in the neck. So allowing for the precise incision and placement of the tracheostomy tube into the trachea. So that this instrument will help to prevent the injury to the surrounding structure during the surgical procedure. So this one is the cricoid hook. Moving to the next question. So answer is D here. Moving to the next question. Tooth extraction in irradiated bone can be performed by administering hyperbaric oxygen. The answer is B. Between 20 to 30 dives before extraction. So that by what we do here is to increase the tissue oxygenation and promote healing, so that can reduce the risk of complication during and after the extraction. So answer is B. So this is a HBO chamber where hyperbaric oxygen is delivered. A 80-year-old male patient was treated with skeletal pill fixation for the mandible fracture as seen in OPG, which result in failure. What could be the next treatment? The next treatment is to give load-bearing reconstruction plate. So you can see here a fracture. So in case of severe atrophic mandible, load-bearing reconstruction plate that are used that will provide a strong and stable fixation. So in order to provide a strong and stable fixation for the fracture, especially in atrophied bone. So in atrophied bone, you need a load-bearing reconstruction plate. So these plates will distribute the forces across a broader area. That will reduce the. So in order to restore the bone volume and enhance the stability of reconstruction. Hand sanitization should be done before touching the patient, after touching the patient when hands are soiled enough, touching the surroundings of patient. This was a question was asked in one of your INICT exam. So the answer is option A, B, D. So before touching the patient, after touching the patient, and after touching the surroundings of patient. So these are the critical points at which hand hygiene should be undertaken to prevent the spread of infection as per the WHO guidelines. Anti-mongoloid slant, it is a feature of which fracture? It is feature that is associated with Lee-Ford 3 fracture. So Lee-Ford 3, it is also known as craniofacial disjunction. So in the Lee-Ford 3, what you will see, there will be separation of the midface from the cranial base. So one of the main features that is associated with this fracture is fracture in the change in the orientation of eyes. So this one is the mongoloid slant and this is anti, just opposite of that. So there will be flattening of midface and anti-mongoloid appearance. So the eyes may appear wider, apart and more horizontally oriented than in their normal position. So this is feature of Lee-Ford 3 fracture. So during extraction of maxillary third molar, a frothy blood bubbles seen with each breath. So the correct initial response in this situation is to perform primary closure of the wound. So you will suture the extraction site to create a barrier and prevent the entry of fluids into the either bacteria or foreign matter into the maxillary sinus. So after you do a primary closure, the patient, you should be closely monitoring the patient for sign of complication, either infection or sinusitis. So this the frothy blood bubbles indicates the communication between the oral cavity and the maxillary sinus. So do a primary closure and wait. Option B, extracting the third molar. It's not advisable. It can potentially worsen the communication between oral cavity and the maxillary sinus. So delay the extraction until the wound has healed and communication it has been closed. Cadwell procedure, it is a surgical procedure that is used to treat chronic sinusitis, and it is not typically performed in response to acute communication between the oral cavity and the maxillary sinus. So that is also not correct. Do nothing. So that is not a suitable action, as it can lead to complications such as sinusitis or infection. Which of following cannot be used when patient is used to allergic to lignocaine? So when the patient is allergic to lignocaine, alternative local anesthetic may be considered. So prilocaine, it is alternative to lignocaine. In patients who are allergic to allergic or sensitive to lignocaine. Saline, well, it is not a local anesthetic, it is a sterile solution. Not used. Diphenhydramine, it is an antihistaminic and it is not used as local anesthetic. Procaine, it is another local anesthetic, but it is not typically used when alternative to lignocaine. So prilocaine is your choice. The bleeding from the socket after the extraction of tooth is known as post-extraction bleeding. And it is, if the patient reports within 12 hours. So if the patient reports after 12 hours following the tooth extraction, it is known as delayed post-extraction bleeding. So that can occur due to the dislodgement of the blood clot. Suppose the blood get dislodged, the blood clot get dislodged. That could lead to bleeding. Infection or inflammation in the socket, it can delay the healing and result in persistent bleeding. Medicaments like anticoagulants, antiplatelet drugs that can affect the blood clotting, and even they can increase the risk of bleeding. Trauma or excessive force that can also cause post-extraction bleeding. Moving to the next question. While performing extraction of tooth with forceps, the first apical force will help in, well, the forceps moving the center of rotation more apically. So first pressure you will be applying is remember it's the apical pressure. So why apical pressure is important? Although tooth move in apical direction minimally, by using an apical pressure, what you will do, you will expand the tooth socket. So by applying the apical pressure, the tooth socket is expanded by insertion of beak down into the periodontal ligament. So this apical pressure that would cause bony expansion. And second reason is the center of rotation that would be shifting more apically. So moving to the next question, most common cause of unconsciousness in the dental office, it is, well, the most common cause of unconsciousness in the dental office, it is typically the vasodepressor syndrome. So that is also known as a simple faint. Or vasovagal syncope. So why does this condition occur? So this occurs due to response to various triggers like the anxiety, fear, stress, or sight of blood that leads to sudden drop in fall in BP, and that is why fainting occurs. So the reason it could occur on the dental chair, it is mainly due to the stress and anxiety. So fear of pain or even the sight of the dental instrument can trigger the body stress response. There could be stimulation of vagus nerve that is responsible for regulating the heart rate and BP. So when the vagus nerve gets stimulated, it can lead to drop in BP and blood pressure. So the patient that experience such syncope in the dental chair, it will feel lightheadedness, dizzy, nausea, sweating, and warm. So in order to prevent, we have to reduce the patient anxiety, just providing a calming environment and ensuring the patient they are comfortable. So in some cases, the dentist should administer LA slowly to minimize the discomfort during injection. Or you can place the patient in a reclined position that will improve the blood flow to the brain. So the most common position to manage is place the patient in Trendelenburg position. That will improve the blood flow to the brain. So most common cause of unconsciousness in dental office, it is vasodepressor syncope. Let us discuss about the other options. The option B is orthostatic hypotension. What do you mean by that? The orthostatic hypotension, it means that drop in BP that occurs when the person transition changes from sitting or lying position to standing position. So when the person changes their body position, typically lying down to standing up, so this drop in blood pressure even can lead to dizziness, lightheadedness, etc. So the orthostatic hypotension, it can occur due to conditions like dehydration, insufficient fluid level in the body that can reduce the blood volume, leading to lower blood pressure when standing. Certain medicaments like the antihypertensive drugs, diuretics, they can cause orthostatic hypotension. So the hallmark symptom of orthostatic hypotension is sudden drop in the blood pressure upon standing. The third option is supine hypotensive syndrome. What is that? So it is a condition that occurs during the pregnancy. So when a pregnant woman, it lies on her back, that can cause a drop in BP. So it is also called as inferior vena cava syndrome. So when the pregnant lady lies flat on her back, there is drop in BP and there is reduction in blood flow returning to the heart. So during pregnancy, we know that the uterus, it gets enlarged to accommodate the growing fetus. So it will put pressure on inferior vena cava. So this inferior vena cava, it is the large vein that carries deoxygenated blood from the lower part of the body to back to the heart. So when the pregnant woman, it will lie flat on her back, the weight of uterus, it will compress the inferior vena cava. So main cause is inferior vena cava, it will get compressed. That will obstruct the blood flow. So that can lead to supine hypotensive syndrome. Option D is acute allergic reaction. So it can occur due to the anaphylactic reaction in response to like medicaments or material that are used in dental procedure. So most common cause is the syncope, that is the vasodepressor syncope. It is the main cause of the unconsciousness in the dental office. Let us move to our next question. The grading of TMJ by Sani type 2 classification is, the answer is B. Bony fusion of misshaped head and cut articular, no involvement of sigmoid notch and coronoid process. So the Sani, he classified into type 1, type 2 and type 3 and type 4. In type 1, the TMJ, it is not completely stuck, but the joint, it is deformed. So there is fibrous adhesions that will make the movement difficult. In the type 2, the edges, they are fused by the bone, but the deeper part, they are still free. So this means joint can't move well, but it is not completely stuck. In type 3, a bridge of bone formed between the jawbone and the bone in the upper part of face, that is the zygomatic arch. So there is in the type 3, you will see a bridge across the ramus and zygomatic bone, and along with that you will see elongation of the coronoid process. Whereas in the type 4, it is the most severe type. So whole TMJ, it is replaced by mass of bone. So type 4, the normal anatomy of TMJ is totally destroyed by complete bony block between the ramus and skull base. So answer here is type 2 is bony fusion of misshaped head, no involvement of sigmoid notch and coronoid process. So which of following statement about the flap designing is incorrect during open method of extraction? The base of flap should always be wider than its apex. So yes, this statement is generally correct. In flap design, it's recommended that the base of flap, it is wider than its apex. That is allow for better access and visibility during the extraction procedure. So broader base, it will provide more surgical access and allow the proper visualization of surgical area. The second option, the incision placed to reflect the flap always heal along its length, and shorter incision is always preferred. Yes, we do prefer a shorter incision for the cosmetic reasons. The healing of incision along the length, it depends upon the various factors like the surgical technique, tissue handling, and the individual patient healing capacity. So, the soft tissue heals across the incision and not along the length of incision. And a sharp incision, it will heal. Remember, a sharp incision will heal more rapidly than a short torn incision. A long straight incision will heal more rapidly than a short torn incision. So option B is partly correct. The sharp incision, they heal more rapidly than the torn incision. Always plane the incision so as to rest the suture line on sound bone. So this statement is generally accurate. Placing the suture line on the sound bone, healthy bone, it will promote a better wound healing. So there will be better wound healing and reduce the risk of complication. So suturing to healthy bone, it provides stability. Along with that, there will be proper support for proper wound closure. When releasing incision is made too close to the bone removal, delayed healing results. So releasing incision, they are usually they are used to create additional flap of tissue when needed for better access. Or to prevent tension on the primary incision during closure. So if the releasing incision, it is made too close to area where the bone removal will occur, it can compromise the blood supply. It can compromise the blood supply to flap, or even it could cause tissue necrosis. So that is why your answer here is B. Mark answer B. Moving to the next question. Post-tooth extraction, gauze should be placed for hemostasis. What is the recommended method of placing the gauze? So after tooth extraction, what you will do is place a gauze. So what is the proper way? The gauze, it should be positioned such that when the patient closes his mouth, it fits into the space previously that is occupied by the crown of the teeth. So biting on teeth together places pressure on the gauze, and pressure, it is then transmitted to the socket. So this pressure that would cause hemostasis. So if the gauze, it is placed on the occlusion table, the pressure applied to bleeding socket is insufficient to achieve the adequate hemostasis. So that is why answer is B. Moving to the next question, ecchymosis over the mastoid process. As in basilar skull fracture, it is known as, remember the B. B stands for basilar skull, B stands for battle sign, and B stands for seen in basilar skull fracture. So this the battle sign, it is seen in basilar skull fracture. So remember these two B. About the option B Muset sign. It is a medical term that is associated with, remember, aortic regurgitation. That is a heart valve disorder. So in this, as the patient moves the head up and down with each heartbeat due to the forceful backflow of blood into aorta during the aortic regurgitation. So the patient's head moves or bobs in the rhythm with the heartbeat. So that is the D Muset sign. Battle sign, it is a sign observed with the basilar skull fracture. And the third is B is base of skull. That occurs at base of skull. Battle sign 3B. Remember the 3B. So it refers to the ecchymosis or bruising over the mastoid process. Carvalho sign, so this sign is associated with tricuspid regurgitation. So that refers to increase in the intensity of heart murmur when the patient performs specific action like taking a breath in. So this sign is used by the doctors to help to diagnose and evaluate the tricuspid regurgitation. The Boston sign, it is seen in thyrotoxicosis. That is jerking of lead leg. That is jerking of lagging lead. That is seen in the so ecchymosis of the mastoid process in the basilar skull fracture. It is known as battle sign. Moving to next question. The cow horn forceps, they should not be used to remove deciduous teeth as it may lead to avulsion of premolars. The crier elevator should not be used in children to remove the deciduous root as it may damage to the tooth buds. The first statement, the cow horn should never be used to remove the deciduous teeth as it may lead to avulsion of premolar, is true. The cow horns forceps, they are used for extraction of the permanent teeth and they are not used for the deciduous tooth. So due to their larger size and shape. So using cow horn forceps to remove the deciduous teeth can result in excessive force being applied that could lead to avulsion or displacement of the adjacent permanent tooth like the premolars. The second statement, the crier elevators should never be used in children to remove the deciduous teeth as it may lead to damage. So these are the cow horn forceps. And this one is the crier forceps. So crier forceps, they are the dental instruments used to elevate and extract the teeth. In the children, the tooth buds of the permanent teeth, they are still developing and are located in close proximity to the root of deciduous teeth. So the use of crier elevators in children to remove the deciduous roots carries the risk of damaging the tooth buds of the underlying permanent teeth that can lead to the loss of the permanent teeth. So both the options are true. A 16-year-old patient present for extraction of multiple teeth. In her history, it is noted that she is on ketogenic diet. So most common reason is the phenylketonuria. So phenylketonuria, it is a defect in the metabolism of amino acid. Which amino acid? Remember that phenylalanine. So patient with phenylketonuria should have a diet low in food that contains phenylalanine. So patients with the mitochondria myopathies have problem with energy metabolism. So a ketogenic diet, it means that the diet that is of high fat, low carbohydrate and low protein. So body uses carbohydrate for the energy source, but in a low carbohydrate diet, fat becomes the main source of energy production. A 23 years old male attend your dental practice for appointment. Sight is fit and healthy but has a phobia of dental injection. During administration of inferior dental block, he becomes unwell and faints. The most common cause is the vasovagal attack. So vasovagal syncope, it is also known as neurocardiogenic syncope. So the vasovagal syncope, it triggers your heart rate and BP fall down. So patient become unwell and get fainted during administration of inferior dental block is mainly due to the vasovagal attack. So the other options like stroke, hypoglycemic shock, and myocardial infection, they are less likely in this scenario, and they would present a different symptoms and with a different clinical sign. So your answer is A. The automatic external defibrillator, it is used for all except. The answer is B. So this automatic external defibrillator, its primary function is to assess the patient's cardiac rhythm and, if necessary, deliver an electric shock to the heart to re-establish the proper rhythm. Moving to the next question, the beak of dental extraction forceps, they are always designed angulated in such way that, well, the beak, so these are the beaks of the dental extraction forceps. So they are held parallel to the tooth to be extracted. So that will ensure a better grip and minimize the risk of damaging the surrounding tissue during the extraction forceps. So they always remain parallel to the handle of the forceps. That's your answer. The commonest cause of TMJ ankylosis, well, the most common cause of TMJ ankylosis is the trauma. So the most common cause is trauma, followed by infection. So the most common cause is trauma. Trauma can lead to injury or damage to the TMJ. So that can result in ankylosis, and that is why the joint, it becomes stiff or fused. The infection, it can also cause TMJ ankylosis, but they are less common than the trauma. So answer of choice is trauma. 5 minutes after the administration of inferior alveolar nerve block for extraction of left second premolar, the patient was unable to move both upper and lower lips and unable to close the eyes on same side. So what would be the cause? So the scenario described, it is likely due to the diffusion of local anesthesia into the parotid gland. So that would result a transient facial pulses, transient facial nerve palsy. So it happens when the needle for the inferior alveolar nerve block, it is directed posteriorly, causing the tip of needle to be within the parotid gland. So the LA deposited in this area, it will affect the facial nerve. So facial nerve will cause temporary pulses of upper and lower lips and eye and that is why the patient is unable to close the eye on the same side. So diffusion of the LA into the parotid gland is answer of choice here. A dentist doing extraction of maxillary third molar. The patient was HIV and the dentist got needle prick on the thumb. What should be done? So the treatment of choice here is take lamivudine and zidovudine immediately. So healthcare workers who experience a needle stick or sharp instrument injury, they should immediately begin with the post-exposure prophylaxis. So the lamivudine and the zidovudine, they are the antiretroviral medicaments that will reduce the risk of HIV transmission. So it is important to start this prophylaxis immediately within the hours of exposure for it to be effective. Also, they should undergo testing for HIV and other blood-borne pathogens at various intervals to monitor their status. So answer is D. Moving to the next question. A man sustained injury and presented with fluid coming through nose. What could be the possible fracture? So the basilar fracture, it typically involves the bone at the base of skull, like temporal bone, occipital, sphenoid, and ethmoid. So these fractures, they can cause tear in the meningitis, that is, and leak in the cerebrospinal fluid. So this cerebrospinal fluid, it may comes out of the nose. That is, the term we use is CSF rhinorrhea. So that is characteristic of basilar skull fractures. So moving to the next question, the most common error the dentist make while positioning the chair for extraction is, so the most common error is the positioning the chair too high, making the dentist to raise his shoulder to reach the tooth. So the most common error in the positioning the dental chair for extraction is to have the chair too high. So this error would lead to discomfort, and there will be difficulty in applying the correct force and technique during the extraction procedure. So what should be the proper position? So for the maxillary extraction, the chair should be tipped backward. Maxillary occlusion plane should be 45 degrees to the floor, and the patient mouth should be at level between the operator's shoulder and elbow. That is for maxillary extraction. And for mandibular extraction, the chair should be in upright position. The mandibular occlusion plane, it should be parallel to floor and should be at level slightly below the operator elbow. So remember that for your exam point of view. On administering the posterior superior alveolar nerve block to extract a maxillary third molar, the patient, the tooth in the patient starts complaining of numbness in the ipsilateral tongue and lower lip. So what the block here given was PSA. When the needle PSA it is inserted too laterally, the local anesthesia, it can affect the adjacent nerves. including the branches of the mandibular nerve that innervates the tongue and lower lip. So that can lead to unintended numbness in these regions. So precise needle placement is very important to avoid affecting the nearby nerves, to get anesthetized and provide an effective anesthesia. So due to the insertion of needle too laterally and depositing the solution is the right answer of choice here, as it would numb the branches of mandibular nerve that innervates the tongue and lower lip. So that is the question here. Next question. What topical form of lignocaine local anesthetic agent it is indicated for use on abraded, ulcerated and lacerated tissue? It's 5% lignocaine in base form. So the base form it is used for these type of tissues as it is poorly soluble in water. So it will stay in place and provide local anesthesia effectively. That is why it is used on abrasive, ulcerative and lacerated tissue. So that's why it's the answer. Next question. A patient who underwent a maxillary canine left canine extraction under LA starts complaining pain at the site of extraction but has completed anesthesia in the upper lip. So most probable reason behind this is, so remember it is very common for patient to have a lip anesthesia but to experience pain at the site of extraction. So that occurs due to the early recovery from the pulpal anesthesia compared to the soft tissue anesthesia. So that is why your answer is A. The soft tissue anesthesia, it lasts longer than the pulpal anesthesia. So that can result in the patient will experience pain at the extraction site even though the lip, they will remain numb. In blowout fracture, which of following is seen? So in the blowout fracture, you can see here, in the blowout fracture, so blowout fracture, it occurs when a rounded ball struck the protruding eyeball that results in fracture of the orbital floor. That occurs due to the trauma, it occurs to the inferior orbital rim. So during the blowout, what you will see, the eyeball, they would go backward into the orbit. That causes inophthalmos. That means there is posterior displacement of the eyeball within eye socket. So that gives a sunken appearance. So that can give a sunken appearance. So exophthalmos, that is just the opposite, that is the protrusion of eyeball. It is not the feature of blowout fracture. The bulbar hemorrhage, it is not associated with the blowout fracture. So your answer is inophthalmos. If the fracture angle results from following extraction of mandibular impacted third molar, the immediate treatment should be, the treatment should be transosseous wiring and IMF. So So transosseous wiring involves the wiring the fragment together through hole drill in the bone, and IMF is the use of arch bar or other device to immobilize the jaw. So this treatment it is done to ensure that the fracture segments they are properly aligned and allow for healing process to take place with minimal movement. Gunning type splints they are used for, the gunning splints are used for patient in the when the patient is edentulous in one jaw or in both jaw, or when vertical relation is not known. So it is used in case of edentulous patients. So this is the gunning splint. So that will provide support, stability and proper alignment. So remember, this one is the gunning splint that we use. Dish face deformity commonly seen with fracture of middle third is because of, in case of middle third fracture, the fracture maxilla, it can move in posterior and downward direction. So that could lead to a concave, a dish-shaped appearance of face. So this one is known as a dish face deformity. So that is due to the result of displacement of the midface structures. Which of following is a direct interdental wiring? The answer is Gilmer. So it is the Gilmer direct method of wiring. It is the simplest and most rapid method for immobilizing the jaw. So in this technique, the wires they are directly attached to the teeth. So making it a direct interdental wiring technique. So to know all these other methods, please go to the video of the fracture part from the textbook that we shall be covering. Your most recent patient presents to your office complaining of severe pain in his jaw around the TMJ. He chews 3 packs of gums a day and his wife tells him he grinds his teeth at night. What nerves provide major sensation to the TMJ? Well, the answer is auriculotemporal nerve that arrives from the posterior division of the mandibular nerve and it supplies the posterior portion of the TMJ. While the mesenteric nerve and the deep temporal nerve, they also carry some sensory fibers to TMJ, but the auriculotemporal nerve, it is the primarily nerve that is responsible for providing the sensory innervation to this joint. The first drug of choice to be administered for anaphylaxis is, adrenaline. Epinephrine is the most primary and most critical medicament for treatment of anaphylaxis. So it will act quickly to raise the blood pressure, reverse the bronchospasm, and alleviate the symptoms like a patient may experience like a difficult breathing. And so epinephrine, it is the, remember, life-saving So it is the life-saving intervention in case of severe allergic reaction or the anaphylaxis. Lignocaine, when mixed with mannitol, leads to increased action of lignocaine. It's mainly due to, the mannitol. It will open the perineural membrane. So that will cause enhanced penetration of macromolecules, and that will affect the nerve conduction. So it will increase the success of inferior alveolar nerve block when it is administered along with the local anesthetic solution. So answer is A. The type of retractor that is used for retraction of mandibular ramus. So answer is C. So this retractor, it is a specialized instrument that is used for retracting the mandibular ramus. So that helps to provide a better visibility and access to the surgical site. Next question, while performing labial canine extraction, if large piece of labial cortical plate fractures and remain attached to root and delivered within the tooth, what should be done? So remove the fracture cortical plate to ensure proper healing and prevent complication, and along with that smoothing the sharp edges of extraction socket that will create a favorable environment for the healing. The detaching the fracture cortex and putting it back in socket, it is generally not recommended as fracture piece may not adequately integrate or heal in place, and it can potentiate lead to complications. So option C and D, they are not indicated for a fractured labial cortical plate during the maxillary canine extraction. So our answer is A. Patient comes to you for tooth extraction. He has history of ankle edema, shortening of breath and orthopnea. We discussed this question just back. So answer here is A. So these all are sign of heart failure. So these are indicative of cardiac decompensation or sign of cardiac congestion and possible the heart attack or the heart failure. The commonest bone to fracture, it's the nasal bone. The nasal bone, they are the most common, frequently fractured. So they can occur due to the trauma, accidents or sport injuries. So answer is B. Position of extraction forceps during reimplantation procedure is, it should be always coronal to cemento-enamel junction. So the beaks of forceps, they are placed on the tooth coronal to the cement-enamel junction during the reimplantation procedure. Which of following respiratory condition is most alarming during patient sedation in dental clinic? It's the apnea. Apnea refers to complete cessation of breathing. So, monitor and intervention, they are essentially to ensure the patient airway remains open and patient continue to breathe adequately during the dental procedure. So this apnea, it could be life-threatening. So apnea means total cessation of breathing. Dyspnea is difficult in breathing, and tachypnea is breathing at abnormally rapid rate. And hyperapnea means increase in rate and depth of respiration. So moving to the question, which of following is characteristic of Lee-Fort 1 fracture? So Lee-Fort 1 fracture, it is a type of facial fracture that involves the maxilla, that is the upper jawbone. Bleeding into the antrum, it is the characteristic of bleeding into jawbone, it is the characteristic of Lee-Fort 1 fracture. See, bleeding from the ear, CSF rhinorrhea, first option, it is not typically associated with Lee-Fort 1 fracture. CSF rhinorrhea, it is more seen in fracture involving the base of skull, like the basilar skull fracture. So the Lee-Fort 1 fracture, it results in separation of the midface from the skull that creates a fracture lines that run through the maxillary sinus. So what is the fracture line? The fracture line in the Lee-Fort 1, it typically starts at the nasal septum, extend posteriorly along the floor of the nasal fossa, then it continues through the anterior and inferior wall of the maxillary sinus, and finally it ends near the pterygomaxillary junction. So this part of the fracture will separate the upper part of maxilla, including the hard palate, from rest of the facial bone. So that is why bleeding from the antrum is generally seen in the Lee-Fort 1 fracture. The Lee-Fort 2 fracture, that is also known as pyramidal fracture. The fracture line, it starts at the nasal bone, extends superiorly and laterally along the nasal bridge, and continue downward through the lacrimal bone and ethmoid bone involving the nasal septum and ends at the pterygomaxillary. Whereas the Lee-Fort 3 fracture, the fracture line is extensive and involves the entire midface. The fracture line starts at the nasal bone, extend along the nasal bridge through the medial and lateral wall of the orbit and continue posterior along the zygomatic frontal suture lines and extend through the zygomatic arches and zygomatic suture lines. So this type of fracture separates the entire midface from the skull, and it is the most severe of the Lee-Fort fracture. So in Lee-Fort 1 fracture, the fracture line disrupts the integrity of the maxillary sinus. So that is a large air-filled cavity located within the maxilla. That is why the bleeding from the antrum is generally seen in the Lee-Fort 1 fracture. So the fracture line, it passes through the anterior and inferior wall of the maxillary sinus. So that means that the cavity itself is often disrupted or damaged by the fracture. So the maxillary sinus, we know it contains blood vessels including the infraorbital artery and branches. So when the fracture occurs, it can cause damage to these blood vessels, leading to bleeding within the sinus. So your answer is C. Moving to the next question. What should the dentist be prepared to do for the patient who had sudden hypoglycemic reaction? So if the patient develops the symptoms of hypoglycemia, the dental procedure should be discontinued immediately. If the patient is conscious, the patient should be given some form of oral glucose. And if the patient is unconscious, the emergency medical services should be contacted. 1 milligram of glucagon, it can be injected IM by the rapid intravenous infusion. So the glucagon injection should restore the patient to the conscious state within 15 minutes. Then some form of oral sugar it can be given. So the option A, the oral intake of sugar is commonly method to raise the blood sugar level in the conscious patient. It may not be the most effective or rapid approach in a dental office, as the unconscious patient may feel it difficult to swallow sugar, whereas 1 milligram of glucagon, it can be injected intramuscularly. So that is a fast acting and effective method of treating hypoglycemia. So we know that glucagon, it is a hormone that stimulates the liver to release stored glucose into bloodstream quickly by raising the blood sugar level. So it can be given through the intramuscular injection. That is especially useful if the patient is unconscious or unable to take sugar. So answer is B, 1 milligram of glucagon that can be injected intramuscularly. Which of following is used to prevent bleeding by clot lysis in patient with hereditary clotting disorder? So tranexamic acid, it is a medication that is used to prevent bleeding by inhibiting the breakdown of blood clot through process that is known as fibrinolysis. So it is particularly used in patients with hereditary clotting disorders like hemophilia, or when there is excessive bleeding due to the surgical procedure or during trauma. Option B, plasminogen. It is a precursor to plasmin, an enzyme that is involved in breakdown of blood clots. It is not used to prevent bleeding, but it rather plays a role in the clot dissolution process. Desmopressin, it is a medication that is used to treat certain bleeding disorders like von Willebrand and mild hemophilia A. So how it works? It works by promoting the release of clotting factor from patient's own body. So that helps in some clotting disorder. It does not specifically prevent bleeding by clot lysis. Option D, warfarin, it is an anticoagulant that will help to prevent the formation of blood clots. So the answer is A. Bristow elevator is used for, the Bristow elevator is a surgical instrument that is used in oral surgery to lift or elevate the depressed zygomatic arch. So this one is the Bristow periosteal elevator. So due to facial trauma, It helps to restore the normal anatomy and alignment of the zygomatic arch by gently lifting the depressed bone. So answer is C. Gurian fracture, it is also known as, it is other name for Lefort 1 fracture. So this one we discussed already, the fracture line. It is also known as Lefort 1 fracture. In case of patient with unilateral TMJ ankylosis, the chin if deviated to. In case of patient with unilateral TMJ ankylosis, one TMJ it is fused or immobile. The chin it is deviated to the affected site. So chin if deviated to affected site in the case of unilateral TMJ ankylosis. In condylar fracture, fracture with greater than 5 mm overlapping and greater than 37 degree angulation with the fracture segment, the line of treatment is, well, according to the Peter Warburg second edition, in case of the condylar fracture with a significant displacement that is greater than 5 mm overlapping and angulation that is greater than 37 degree angulation, the fracture segment, open reduction and internal fixation is the choice. So that is the surgical intervention done to realign the fracture segment of the mandibular condyle and stabilize them with screw plates or other fixation device. So that is done to restore the proper jaw function and alignment in case of severe condylar fracture. So answer is B. This question has been asked multiple times in your entrance exam and very, very important for your exam point of view. Which treatment plan will lead to rigid fixation of fracture site? So answer is eccentric compression plates osteosynthesis. It is a technique that involves the applying a compression plate to hold the fracture bony segments together. So that will provide a rigid fixation of the fracture site that is important for proper healing and bone alignment. Moving to next question. During CPR, the chest compression should be performed at rate of 100 to 120 compression per minute. Compression per minute. So to achieve this rate, it is recommended that you compress the chest at the depth of 2 inch. That is 5 centimeter for adults. So you should push down on the zippy sternum or the lower half of the sternum with enough force to depress the chest to this depth. So the CPR rate, the rate of chest compression is around 100 to 120 compression per minute. So that is done to ensure that blood is circulating effectively to maintain oxygen delivered to the vital organs, including the brain. The chest compression depth should be 2 inches or 5 centimeter. So this depth is important to generate enough pressure to pump blood effectively. So it is essential not to press too hard as excessive force it can cause injury. Zippy sternum, it's the cartilaginous part of the sternum that extends downward from the lower part of sternum. So while you perform CPR and do chest compression, you should aim to press down on the center of the chest. That includes the Jiffy sternum and adjacent ridge. So it is possible to fracture the rib during CPR, especially in cases with the older individuals or those with the fragile bones. So proper technique should be used, like placing the heel of your hand in correct position and using your upper body weight for compression. It can minimize the risk of injury. Moving to the next question, in Gillies temporal approach for reduction of zygomatic fracture, Rose zygomatic elevator, it is placed between reduction of the recent fracture can be carried out using the zygomatic arch fracture. It can be carried out using the Gillies temporal approach. So in the Gillies temporal approach for the reduction of zygomatic arch fracture, a row forceps, it is placed between the temporal fascia and the temporalis muscle. So this surgical approach allows for access to the fracture zygomatic arch and facilitates its reduction. So the temporal fascia, it is incised and instrument, it is inserted beneath the zygomatic arch, separating the fascia from the temporalis muscle to reach the fracture site. So answer is C. Again, it is very important question asked multiple times in your entrance exam. Very important for your entrance exam point of view. Battle sign. Battle sign we have already discussed before too. So remember, battle sign refers to the presence of ecchymosis in the mastoid region, typically behind the ear. So this area, as seen in this pic. So it is associated with the fracture of middle cranial fossa of the skull. So it occurs due to the blood that will track down and collect in the area behind the ear due to the skull fracture, particularly in the temporal bone region. So answer is ecchymosis in the mastoid region. Other sign, remember, Goalmds sign. So hematoma in the mandibular lingual sulcus, it is pathognomic of mandibular body fracture. That refers to Goalmds sign. Remember that. And palatal ecchymosis is the Korean sign. Hematoma in post-palatal region due to bleeding from greater palatine artery. Next question, a 40-year-old patient presented with multiple extraoral signs with yellowish discharge and with a history of intermittent remission. After antibiotic treatment 2 months ago, the disease started after the extraction of second mandibular premolar. That's suggestive of actinomycosis. The clinical presentation described involves the history of the dental extraction, as here second mandibular premolar was extracted, with the patient complaining of multiple extraoral signs, drainage, the extraoral drainaging signsing, history of remission and healing is suggestive of actinomycosis. Along with that very important feature, that is presence of sulfur granules, yellow color discharge, it is suggestive of actinomycosis. That is a bacterial infection that is caused by actinomycosis. So your answer is actinomycosis. Mark that. This question is very important and ask examiner favorite question. In vasovagal syncope, which of following does not occur? So remember, constriction of pupil, it is not a symptom of vasovagal syncope. Instead, pupillary dilation that is commonly occur. So in vasovagal shock, there is vasodepressor response that lead to drop in BP and bradycardia. So that response is often associated with symptoms like pallor, sweating, vomiting, yawning, and feeling of warmth. So the patient complains of feeling of warmth in neck, loses color and baths in the bead of cold sweat. During exodontia, it is seen that the tuberosity which is fractured but remain attached to mucoperiosteum with intact blood supply. So the treatment should be reposition the fragment and stabilize it with sutures. So in case where the tuberosity is fractured during exodontia but remains still attached to mucoperiosteum with the intact blood supply, the preferred method is to reposition the fractured fragment and stabilize them with the sutures. So that will allow our aim is here to promote proper healing and allow union of fractured tuberosity, so allowing it to remain functional. So removal of tuberosity, it is not typically your first choice because the preserving the tuberosity, it is important for retention or fabrication of artificial dentures. So answer is D. For a patient undergoing anticoagulant therapy who requires unavoidable dental surgical treatment, the dental surgeon should. The answer is D. They consult the physician of the patient for joint decision. So when the patient is undergoing anticoagulant therapy and he requires a dental surgical treatment, it is essential for dental surgeon to work closely with the patient physician to make informed decision regarding the management of anticoagulation therapy before, during and after the dental procedure. So patient on the long-term anticoagulant should discontinue the anticoagulant at least 4 to 5 days prior to surgery with the physician consent. So if the discontinuation of oral coagulants is not advisable, the patient should be shifted to IV anticoagulants like heparin. According to you, the best and most effective position of mini plates as provided by various experimental study, it's the linguo-alveolar region. According to the Rowe and William, the experimental studies have shown that most effective and favorable position for mini plate fixation in mandible, it's the linguo-alveolar region. Because this region it is chosen because it experiences the greatest tensile force during mandibular function and make it an ideal site for fixation. The mandibular fracture they are managed by adapting reconstruction plates is an example of load-bearing osteosynthesis. So mandibular fracture managed by adapting reconstruction plates, they are a type of load-bearing osteosynthesis. So in this approach, the reconstruction plates, they are used to provide rigid fixation and stabilize the fractured mandible, allowing the plate to bear the load and share the mechanical stresses during the healing process. Whereas the load sharing osteosynthesis involves smaller, less rigid fixation device that distribute the load across the fracture segment rather than bear the full load. So the reconstruction plate, on other hand, are designed to provide strong load-bearing support and are often used in more complex mandibular fracture to ensure stability. So mark answer A as your answer of choice. Risdon wiring, it is indicated in management of fracture of mandibular symphysis. It is a technique used for management of fracture of mandibular symphysis. So in this, the wire, they are passed around neck of second molar on each side. Their ends are brought out on the buccal side. The ends of the both wire, they are then twisted together and providing stabilization for the fracture segment of the mandibular symphysis area. The recommended position to keep a person who faints during extraction is the Trendelenburg position. So when a person during dental procedure, recommended position to keep them faints, our position is to, the dentist position is to keep them in a Trendelenburg position. So the position involves lying the patient flat on their back with the head lower than the feet. So that will bring blood. So feet, they are at higher level, the head is at lower level. That will bring the blood to the brain by using the gravity. So that will assist in restoring blood pressure and cerebral perfusion. So placing the patient in Trendelenburg position helps to promote the recovery from the syncope. Antibiotic cover is mandatory in following condition of heart before extraction. So answer is congestive heart failure. So the antibiotic prophylaxis, it is recommended for patients with congenital heart condition before the dental extraction. So the goal is to prevent the infective endocarditis, that is the potential serious infection of lining of the heart valves. So antibiotic prophylaxis, it is given to reduce the risk of bacteria from the mouth entering into the bloodstream during the dental procedure and causing infective endocarditis. The patient with bilateral subcondylar fracture will present with the anterior open bite. So inability to open mouth, it is more commonly associated with the trismus. So in patient with the bilateral subcondylar fracture, it is common to observe an anterior open bite. So that occurs due to the fracture condylar process that are responsible for the posterior part of the mandible moving upward and backward during the mouth closure. So they are not functioning properly due to the fracture. As a result of that, the anterior part of mandible, it may move downward and forward, leading to anterior open bite. Total joint prosthesis replacement, it is not done in, the answer is B, recurrent dislocation. So total joint prosthesis, it is not typically done for treatment of recurrent dislocation. So that occurs due to that are related to ligament, due to the muscle dysfunction or other anatomical factors. So the management of recurrent TMJ dislocation includes involves the non-surgical approach like the physiotherapy, use of occlusion splints. Total joint prosthesis, it is more commonly indicated for conditions like tumor of condyle, avascular necrosis, and advanced osteoarthritis, where conservative and less invasive treatment they are ineffective in providing pain relief. So answer is B. One day after complete mouth extraction, blue-black spots are seen on the neck of patient. So the blue-black spots on the neck of a patient 1 day after complete mouth extraction is post-operative ecchymosis. Ecchymosis means that there is leakage of blood into the surrounding tissue. Whereas the thrombocytopenia purpura, it is a blood disorder that is characterized by low platelet count. In here there will be petechiae and bruising. And it is not associated with localized ecchymosis. Impaired blood circulation may cause various symptoms, and it is not cause of blue-black spots in the region. Cellulitis, it is a bacterial infection that can cause redness, warmth, swelling, pain, but not associated with the development of ecchymosis. So our answer is B. Daughtry procedure, it is used for chronic recurrent subluxation of TMJ. So here the procedure involves downfracturing the zygomatic arch and placing it in the front of condyle. Hayton-Williams forceps, it is used for the maxillary fracture. So remember, these forceps have two divergent curved beaks. So these are the two divergent beaks. You have to the dentist just engage the maxilla with these beaks behind the tuberosity. So here and here. So it is used for the maxillary fractures. The next question, the bowstring test, it is used in naso-orbitoethmoid fracture. So the bowstring test, it is used in case of naso-orbitoethmoid fracture to assess the integrity of attachment of medial canthal ligament. So you have to, the test involves pushing the lateral canthals of eye outward. So if the medial canthus is now triangular and has become round, it indicates that medial canthal it is detached. That suggests the presence of naso-ethmoidal fracture. The grading of TMJ ankylosis by Sony type 2 is, this question has been discussed, the answer is B. So that was all about